medical student here at Yale. She's originally from Chicago, went to Case Western Reserve University. While at Yale, she's been involved in basic science research. She did a Howard Hughes fellowship over a 2-year period here. She's involved with the student-run free clinic. And today she'll be presenting on male infertility, a biomarker for prostate cancer.
Hello, everyone, and thank you so much for this opportunity to present today. I'm really excited to be back since my rotation back in June and July. So today my talk will be on male infertility and its role as a biomarker potentially in prostate cancer. So at the end of my talk, I hope that you'll have a basic understanding of the epidemiology of male infertility and prostate cancer, be familiar with some of the main studies in this field, and also be able to describe the role of DNA mismatch repair genes as a possible mechanism underlying the association between infertility and cancer. Firstly, what is male infertility? Infertility is defined as the failure to conceive despite 1 year of regular unprotected intercourse. Unfortunately, about 15% of couples will experience infertility. 20% of these cases will be solely due to a male factor, and another 30% of cases are due to both male and female factors simultaneously. And although somewhat controversial, there are studies that suggest that there has been an increase in incidence and prevalence of male infertility over the last few decades. For example, a study that was conducted in Saudi Arabia suggested that the prevalence of male factor infertility in one of their centers has increased from 2008 to 2014. And so as you can see, male infertility has become a major medical condition that affects a sizable portion of the population, and more specifically, the population that we treat as urologists. Now, we all know that prostate cancer is one of the most common malignancies that affects men, and its incidence increases with age, with the average age of diagnosis being 66 years old. What we don't have a true understanding of is the etiology of prostate cancer. And although there's a lot of literature describing some of the well-known risk factors, which include age, family history, genetics, and race, what I like to propose today is perhaps reproductive health, and specifically infertility, could be considered as another risk factor for prostate cancer. And to describe this, I'm going to be talking about 3 landmark cases in the field today. The first case I'm going to be talking about is by Jorgensen et al. That was conducted in Denmark. And in this particular study, they designed it so that fatherhood status or paternity is used as the surrogate marker for infertility. And what they did is they followed a cohort of men born in Denmark and followed them to see the incidence of prostate cancer among this group. And although they report quite a bit of data, for today, I would just like to focus on the top of this chart, which shows that perhaps there's a 16% reduced risk of prostate cancer among men who are childless compared to men that have had 1 or more children. And so what they conclude is that perhaps there's a lower risk of prostate cancer among childless men. Or in other words, perhaps there's no increased risk of prostate cancer among infertile men. But I would argue that studies such as this have a large weakness, and that is the fact that they use paternity as their surrogate marker for infertility. And that's because these men may not have had children because they were infertile, but also they may not have had opportunities in life to have children. They may have been with a female partner who was infertile, or they may have chosen not to have children themselves. And so many studies since then have often used sperm analysis and abnormal sperm analysis as their method of determining infertility. One of the most well-known studies that was conducted in the United States was done by Walsh et al. And what this group was able to do is they identified men at one of 15 infertility centers in California and linked their data to the California Cancer Registry, and then looked at the incidence of prostate cancer among men that were evaluated at this center and found to either have or not have infertility, and compared this incidence with an age-matched and geography-matched control group. And what they found is when looking at the overall risk factor or risk for prostate cancer, men that were evaluated and found to have infertility had a somewhat increased risk, but small increased risk for prostate cancer overall. Whereas men that were evaluated at these centers but not found to have infertility did not have this increased risk. but some would argue that this risk is relatively small and clinically insignificant. But this group also looked at high-grade prostate cancer risk. That is, at time of diagnosis, these patients had a Gleason grade of 8 through 10. And men that had male factor infertility had a twofold increased risk for this type of cancer, whereas there was no increased risk for men that did not have infertility. And when looking at low-grade prostate cancer, there was no association between infertility and low-grade prostate cancer. And so this group concluded that men with impaired semen quality are at an increased risk for high-grade prostate cancer. And so already we can see quite a bit of contradiction between major studies that have been done in the field. And so most recently, and extremely interestingly, just published earlier in September, there was a study that was done in Sweden that looked at the risk of prostate cancer among men who underwent assisted reproduction in order to have a child. And what's interesting about this study is that in Sweden, the main indication for ICSI, or intracytoplasmic sperm injection, is male factor infertility, whereas IVF is used mostly for female factor infertility combined with either normal or mildly abnormal sperm analysis in the male partner. And so this group identified more than 1 million fathers to firstborn children in order to avoid replicates, and then looked at categories of men that conceived their child spontaneously or underwent IVF or ICSI, and then looked at prevalence of prostate cancer. And shown here are the results from this study. What they found was that the overall risk for prostate cancer, when looking at the group of men that underwent IVF or ICSI compared to natural conception, both groups had an increased risk for prostate cancer, with the ICSI group being larger. But looking at early onset prostate cancer risk, which this group defined as being diagnosed with prostate cancer at an age of 55 or younger, there was, again, an increased risk in both groups, with the ICSI group being as high as 1.86. And so this group suggested that male factor infertility is not just associated with prostate cancer, but really early onset prostate cancer. And this is significant because, as we know, early onset prostate cancer is somewhat different from the prostate cancer we see in the elderly. These cancers tend to be more aggressive, and the tumors themselves tend to be less differentiated. And so perhaps we have identified a pertinent subpopulation of men that require follow-up, and really closer follow-up, for prostate cancer in order to save their lives later on. And so there are a number of biological mechanisms that might underlie this association between infertility and cancer, because looking at this from this perspective, initially, there seems to be no reason why infertility and cancer, two very different pathologies, could be related. And now there are a number of hypotheses out there that are listed here, and I'm happy to answer questions on any of these if they come up. But for today, I'd like to focus on DNA mismatch repair genes. We all know that DNA mismatch repair genes are important in cancer and tumor genesis as a whole, because with the loss of these genes, you have microsatellite instability in the genome, and this leads to predisposition to early onset tumors such as Lynch syndrome and colon cancer. But their role in infertility is much more novel and less understood. For today, I'm going to be focusing on the gene MLH1, which is one of these mismatch repair genes. And in human patients, a defect in MLH1 has been associated with patients that have non-obstructive azoospermia, and more specifically, Sertoli cell-only syndrome. And so in this immunohistology slide, you can see here, in a fertile human patient, control patient, you can see expression of MLH1 diffusely through the cytoplasm, as well as attenuated around the nucleus. But in a patient that has non-obstructive azoospermia, you lose this pattern of localization of this protein, and it becomes mislocalized to what it seems to be in the nucleus of these cells. And so this we could consider to cause a loss of function in these cells, leading to some abnormalities that lead to infertility. So the next question is, why does this occur? There have been a number of studies in different animal models, including zebrafish, that have looked at what happens when you lose MLH1 in terms of infertility. In this particular study, these researchers were able to create a knockout line with MLH1 deficiency, and what they saw were zebrafish that phenotypically looked normal and even had normal behavior. But when they looked at the fertility of men, of the male zebrafish, they found that these fish were 100% sterile. When they looked at the histology of the testis, in a control zebrafish, What they saw were sperm cells that were undergoing all levels of spermatogenesis. That is, you have sperm cells that you can see in the center that were spermatozoa that are mature and ready to go into the epididymis, and you have cells undergoing mitosis and meiosis, both 1 and 2. But in these mutant zebrafish, where there's no MLH1 present, you have cells that are arrested at metaphase 1, and so cannot undergo further meiosis. And so these cells eventually undergo apoptosis or cell death, and this leads to lack of mature sperm in these animals, and therefore leads to infertility. And so for today, I'd like to conclude my talk to say that male infertility is a significant problem in the population that we treat as urologists. Although there is a lot of conflicting data in the field, I think the most recent study by Ghaffari et al. Suggests that perhaps infertile men are at an increased risk for prostate cancer, and further studies are necessary in order to determine perhaps what subgroup of patients require follow-up, how long this follow-up is necessary, and what this would entail for this group, especially when we're considering early onset prostate cancer. And then lastly, although there's a lot of interesting research already conducted, further research is necessary to better understand the mechanism of how these two very different pathologies are linked together. Thank you again for this opportunity to present. I'm happy to answer any questions.
That was a wonderful job. Great that you really led in with some elegant epidemiology studies and a potential genetic correlate. One of the clear risk factors for developing prostate cancer, being diagnosed with prostate cancer, is seeing a urologist. I don't know, and that was a large part of the story of the association between vasectomy and prostate cancer. Have any of the studies looked at or attempted to control for prostate cancer screening and differential opportunities for identifying prostate cancer?
So unfortunately, one of the weaknesses that many of these papers themselves cite is the fact that they often don't look at whether or not these patients have done PSA level testings, what their further follow-up is in terms of urology and its care. But I would argue that, I can go back, that some of these associations that we see, for example, in this study, the fact that there's an increased risk for high-grade prostate cancer, but not really low-grade prostate cancer, for example, suggests to me that it's not necessarily the exposure to the medical care necessarily that's causing this risk factor to be present, and perhaps it is something else that we're seeing, but that is definitely something that, unfortunately, none of these studies have been able to control for.
This may be a little bit dated, but quite in the past, that hypogonadism will testosterone. Where does testosterone?
So a lot of these earlier studies with paternity were done initially because of the concern that there's perhaps an androgen correlate between both infertility and prostate cancer. But I would say that because a lot of those studies suggest that there is actually, they didn't find that correlate whatsoever, they're not sure at the moment. That's the best I can give you for that answer.
Thank you for the talk, really wonderful. Could you draw a line between MLH1 and prostate cancer? I'm not familiar with genetics, I'm sorry.
No, I don't have an exact paper for you for prostate cancer specifically. MLH1 has been found in a number of different cancers, especially colon cancer, but I don't unfortunately have one specifically for prostate cancer. Thank you so much.
All right, next we'll have our next visiting student. So this is Helya Ghaffari. She's originally from Maryland. She went to the University of Maryland, Baltimore County. She's currently a fourth-year MD PhD student at the Mount Sinai Icahn School of Medicine. Her research is involved with drug discovery and cancer biology under Dr. Prem Kumar Reddy. And today she'll be presenting on optimizing prostate biopsies in the MRI era.
Hello, everyone. Can you hear me? Thank you so much for this opportunity. I I decided to present on this because while I was in clinic following Dr. Liebman and saw how Artemis was being used, it was interesting to me how there were variations between the protocol here, the protocol at my home institution at Mount Sinai. And upon talking with Dr. Liebman and doing some literature research, I found that because this technology is still new, it's not actually yet part of any guidelines. But there have been some studies done, which is what I'll be focusing my presentation on. So as a brief reminder and background, there are AOI guidelines for biopsies indicated in men with elevated PSA or abnormal DRE exams. But these guidelines focus around a template or a strategic biopsy. And they're done with transrectal ultrasound guidance following this sort of pattern. And there have been the studies that provided the evidence for establishing these guidelines compared the extended 12 core, which is what we do now, with the sextant. And they found that this 12 core did in fact allow for increased cancer detection rate and increased negative predictive value. However, these are, as I mentioned before, compared with a sextant, so a similar technique, just with fewer biopsies. And they also did have the kind of the asterisk point that the 12 core did, in addition to having an increase of increased cancer detection rate, there was also an increase in detection of indolent cancers. It's ones that didn't really change management. And for anyone that's not yet familiar with or haven't seen this at work, the Artemis is a form of MRI and ultrasound fusion technology that allows for a targeted biopsy. So before the patient comes in, they have an MRI that detects the lesions. And then in the clinic, they have an ultrasound done in real time. A fusion is done and it creates this 3D image, which you can also overlay the pattern from the template, as well as highlights the areas of lesion, and then the needle can be guided. And this can actually, the ultrasound can be done transrectal or transperineal. What's beautiful about this is because there's a recording of where the needle goes in active surveillance, you can actually rebiopsy the same area. So this kind of begs the question, which is, how does these fusion targeted biopsies have a role in active surveillance? Now, for something to become part of a guideline, there are multiple areas that you can establish or look into to provide the evidence for making it part of the guideline. But for interest of time and purposes of this talk, I focused on improving cancer detection. And this can be divided in two things. First is, of course, sensitivity. Is it able to pick up cancer at the rates that we need it to and at the current gold standard? And this can be looked at whether it is able to detect cancer alone or in combination with the strategic biopsies. And specificity, as I mentioned before, the 12 core biopsy does have an increased rate of indolent cancers. So what are the rates that the targeted biopsies are able to detect a clinically significant cancer? So this part wasn't a huge surprise. The targeted biopsy has an increased detection of clinically significant cancers. And at UCLA in 2014, a study was done looking at a consecutive case series of 105 patients who had prior negative biopsies but continued to have elevated PSAs. And upon targeted biopsy, they found that though the diagnosis between the targeted and the strategic biopsies were the same, the targeted biopsies actually had an increased rate of clinically significant disease, which kind of makes us wonder if the ability to actually hone in on a particular lesion allows for this increased rate of clinical significant disease versus the the randomness, albeit organized way of the strategic template. So here's a graph representing that data. Oops. Okay. And you can see that there is a strong increase in the targeted only biopsies in terms of their ability to detect the significant cancers. But I also want to highlight that when you do the combination, in this case, it has what looks like more of an additive effect. All right, and then a study was done in a retrospective study on men who had biopsies between 2012 to 2015 to evaluate how the targeted biopsy affected the Gleason score, considering that prostate cancer is a pretty heterogeneous disease. And in this case, 3 to 7 cores were taken from each lesion target, and with an average of 2.7 cores detecting cancer. And this part was particularly interesting that 51 out of 70 patients targets had 2 or more positive cores, whereas 12 to 70 had a single positive core. And when the patients that had 43% of the patients that had the targeted biopsy actually had an increase in their Gleason score. And here we can see a graphical representation of this, where when they had the patients that had the strategic biopsy alone, you can see that although it can detect intermediate and high, there's still quite a bit of low cancer risk detected. And with a similar rate in patients that had a targeted biopsy but had an initial lower Gleason score. But patients with a higher Gleason score at their initial biopsies, they had upon the targeting, we can see a strong shift towards the intermediate and high. And what's particularly interesting about this is, again, the combination of the strategic biopsy with the targeted biopsy had a similar result where there was a strong shift towards increased risk. And so this is not just in the States. In India, a study was done looking at men with an indication for prostate biopsy. Since this population actually generally has a lower risk, so this was particularly interesting for that reason, that it's a group that's not necessarily at a high risk for prostate cancer, and they found that both methods had detected patients with cancer. But what's interesting is that though both had 33 out of 36 patients with of the 36 patients that found to have cancer, and both detected 33 of them, there were 3 patients in the strategic biopsy group that were not detected by the targeted biopsy group, and then likewise there were 3 patients in the targeted biopsy group that were not detected by the strategic biopsy group. So that's about a little less than 10% of the patients with the cancer. And clinically, in patients that are clinically with a clinically significant disease, again, they're quite similar, although the targeted biopsy did detect them more. So this would represent patients that have a generally lower risk, but would still require screening per the guidelines. So this, one of the big things that I saw that was different between how things were done at Sinai and the protocol here was the number of core biopsies taken. And fortunately for me, Dr. Sprinkle had a paper looking at this. And they looked at retrospective study on patients who underwent a biopsy from 2012 to 2017. And they found that by having 2 cores dissected, they had they detected 77% of clinically significant cancers, and by 5 cores, they detected nearly all of them at 99%. So here's a graph showing that there's a plateau after 5 cores, and actually those patients that are on active surveillance, there's an even steeper curve compared to patients with that are biopsy negative. So I've been alluding to this throughout my presentation about this concept of combining the fusion with the systemic biopsy. And studies have been done looking at particularly that, which is, so at Cornell, they looked at 240 men to see if the targeted biopsy and the strategic biopsy combined allowed for increased rates of clinically significant cancer. And they found that when you added the strategic biopsy, there was a bump in the Gleason score in 5.8% of cancers, and in 4.1% of the patients, they actually upgraded from an indolent to a clinically significant cancer. So that's when they added the strategic biopsy along with the targeted. It should be said that this did correlate with an increased age. And of the patients that had the upgrade from clinically significant prostate cancer, none of those patients did have a negative biopsy associated with them prior. So there were patients that were on active surveillance. And in France, a prospective multi-center paired diagnostic study was done, and I think it was in Paris, where they looked at the ability of the images to detect alone to detect clinically significant cancer in the biopsy negative patients. So are these images able to pick up everything? And what they found was, of these patients, there were 14% that were diagnosed by a strategic biopsy alone, and about 20% by targeted biopsy alone. And this difference isn't statistically significant. So they're about the same at being able to identify cancers that the MRI missed. And but in this case, whereas before in the previous study was an added effect, this study actually showed that there's a synergistic effect where when you combine the two of them, it resulted in 66% detection. And so they recommended that the detection improved with a combination of both techniques. And so then this additional study was done to look at looking back at patients, 122 patients on active surveillance with 2 consecutive MRIs that had a targeted biopsy or a strategic biopsy. And they found that those with the initial MRI that were negative, that 72.8% had a GG1 disease. But in patients that had negative image findings on follow-up, which were 33 of them, 51.5% had GG1 disease and 6.1% had GG2 disease. So this is with patients that had negative images to begin with, but continued to have biopsies at their initial visit, and then later had biopsies done. Now this study actually shows patients that had lesions identified on MRI and separated into a PI-RADS of less than 3, 4, and 5, and they found that when they did the biopsies, there was actually a shift in their significance in the patients that had a PI-RADS of 4 and 5. And this worked with both initial and with follow-up. And so a lot of the studies were done looking at the false negative rates, but there were also false positives with the targeted biopsy. And the pathology report came last year that showed again, retrospective study looking at this enormous surgical database of patients that had no cancer detected on biopsy. Or they identified the patients that had no cancer detected on biopsy, but were found to have lesions. And it shouldn't be a really big surprise to us that it was a very small group of patients of 544. They identified 41 that met this criteria. And they described that things that can contribute to this are inflammation, stromal, nodular hyperplasia, adenosis, squamous metaplasia, basal cell hyperplasia, and skeletal muscle. And in fact, one thing that the targeted biopsy does give you a risk for is it's most commonly going to pick up basal cell hyperplasia, as well as it had a higher ratio of the stromal nodular hyperplasia. So here in panel A, we have a normal prostate biopsy, beautifully done. And in B, we have an atrophic gland with increased stroma, so something that we may pick up on a targeted, but is not cancer. And in C is an example of a stromal nodular hyperplasia, and D a basal cell hyperplasia. So to summarize, I hope that I was able to convey to you the advances in technology that have allowed for improvements in prostate cancer screening, both in new diagnosis and patients in an active surveillance, in particular in relation to giving a more accurate of a Gleason score, and in that way we can more accurately represent the heterogeneity of the samples. And there still continues to be a strong role for the strategic biopsies that are part of the guidelines, especially when combined with targeted biopsy. And in fact, the studies right now recommend to continue doing the targeted biopsies, even if the targeted is still is part of practice. And in fact, in patients that have negative results on the strategic biopsy, at that point, can you consider only doing targeted? So these are my references. And thank you.
That was a very nice talk. I have just two questions, and you may not have the answers, but one of the questions is, anyone looked at comparing what they call saturation biopsies compared to doing systemic and targeted biopsies? In other words, if you just do tons and tons of biopsies, you're going to find more cancer. And then the other question is, if you do systemic plus targeted biopsy, and then say the next year you do an MRI and there's no change in the findings on imaging, is there any reason to do another biopsy?
For your first question, I didn't come across any studies that looked at saturation specifically, but I can imagine that with the slide I showed that there was a plateau.
I can save you on that one. So there is data that with increasing number of biopsies, there is increased likelihood of cancer detection. That's been published in several different studies. I don't remember the author, but there is an elegant study, sort of mathematical, looking at is a targeted, including targeted biopsy, is that just an increased detection rate based on increased number of biopsies? And it was not. So there is an increased detection based on the targeting specifically that cannot be explained only by increasing the number of biopsies. So could you potentially have, with a saturation biopsy, we were taking a 3650 course, equal cancer detection rate to a target biopsy? Probably. With a transperineal template mapping biopsies, where they biopsy at 3 millimeter intervals the entire prostate, that has the same or better detection rates than MR targeted biopsy. So that's the basis for the PROMISE study. That is sort of the foundation for a lot of this MR stuff that we're talking about now. They did saturation template transperineal biopsies, and that's the gold standard. So that's considered basically equivalent to a radical prostatectomy, even though it still is a slightly decreased detection, but it's about 98% detection compared to a radical prostatectomy.
Yeah, well, can you remind me what your second question?
Second question was, if there's no change in your MRI image, say the year after your first do your biopsy, do you have to do another biopsy if the imaging is exactly the same?
So I didn't come across anything that had looked at that specifically. It looks like Dr. Sprinkle may know, but I would have to, if I was to kind of think about what I have seen, I would imagine maybe you don't need to do a strategic biopsy, but it could be worth continuing the targeted to see if there's any change in the cells.
So Walter Sang's paper, which is the last one you put up there, we kind of addressed that. I mean, we only had 120 patients where we looked at this subsequently, but MRI in a multivariable analysis is not predictive of progression. And so we did not see any change in the MRI. We did see, as she showed those graphs, that if you have a higher PIRADS, you have a higher likelihood of having cancer detected on a subsequent biopsy, but that's independent of what your later MRI is. So if it doesn't change, it doesn't mean that you have no risk. So I mean, we look at people who had a PIRADS 4 or 5, they only had Gleason 6 detected. This is a cohort of people that only had Gleason 6, right? So you still have a 40% upgrading if they had a PIRADS 5 on their first one, especially if they had a PIRADS 5 on their second one, they still have a 40% chance of upgrading on their subsequent biopsy. So I would say at this point, I still favor biopsying these people independent of the MRI. The real question is there a value of repeating the MRI? That's kind of what we're trying to figure out. And I think you can make a case there probably is not a value in doing it every year. We're still doing that as we try to figure out what the optimal timing of that is.
For Preston and for you is, you know, my experience that if I wanted to find a positive, clinically significant prostate biopsy, I'd have Ralph DeVito do the biopsy. But in the era of MRI, the big question I have is, it seems like you can get these anterior lesions much easier than we could with Sub-Int or, you know, 12 sector biopsy. Is that really what we're seeing, is this ability to get these anterior lesions that we couldn't historically, and that's why we're seeing this uptick in detection of clinically significant biopsy with MRI?
So, yes and no. So the lesions that are identified are often anterior. Those are the ones that are often missed, but there are innumerable examples where it's a small lesion that we are detecting in the peripheral zone that's just missed by a section biopsy. Traditionally, we were detecting larger lesions. I mean, sometimes you'd get the right one, but it was kind of a crapshoot. So now, definitely the anterior ones being picked up and in larger glands especially, we're getting the anterior ones better, but also in larger glands, we're also getting ones in the peripheral zone that you just aren't able to sample because we are randomly putting needles in, even with the template biopsies.
Thank you.
Our last student presentation for the day is visiting medical student Jazzmyne Montgomery. She's a fourth year at Loyola in Chicago. She went to University of Wisconsin-Madison for her undergraduate degree. She also has a Master of Science from Roosevelt University. Prior to medical school, she implemented the Let's Move campaign initiatives for Children's Health Collaborative in Northern California. She was a Schweitzer Fellow and the Associate Director for Medical Mavens Mentorship Pipeline, has been able to serve communities burdened by health disparities and socioeconomic burdens. She's authored several publications encompassing topics from timely diagnosis and effective management of uncommon genetic forms of diabetes to BPH medication prescribing patterns, predictions of increased narcotic use after ureteroscopy with stent placement, and risk factors for recurrent priapism. Today, she will be continuing our prostate cancer theme by discussing some racial disparities in prostate cancer.
Good morning, everyone. Thank you so much for giving me this opportunity to speak for you today, especially on a topic that I am very, it's near and dear to my heart. You know, unfortunately, my family has been affected by prostate cancer. And I do hope that in some small part with my career, my future career as a urologist, I can help to expand the landscape as it relates to health disparities in African American men with prostate cancer. Active surveillance for the management of low-risk prostate cancer has been increasing in the general population because it appears safe and it mitigates the harms of prostate cancer screening, like the risk of overtreatment. But this conversation as it relates to African American men has many, many moving parts, as shown here, particularly because these men have worse outcomes. So I'll be touching on a very small, superficial portion of that. This conversation can go on for hours, but I wanted to introduce that. So the racial disparity in outcomes for this population is very well known. SEER data has not only shown that Black men have the highest incidence of prostate cancer, but they have a 2 to 3-fold increase in mortality as compared to white men. They also have evidence of more aggressive disease. And unfortunately, an optimal screening regimen for men at the greatest risk of mortality from prostate cancer still isn't known. And so given this disparity in outcomes for specific groups, The AUA recommends earlier screening prior to 55 for potential benefit in this population. And specifically in the setting of low risk and very low risk prostate cancer groups, active surveillance becomes an important part of the conversation. And so in the context of racial differences and potential explanations for differences in prostate cancer outcomes, which some are shown here, the safety of active surveillance for Black men in the low risk and very low risk groups has been debated. And so that brings me to this very high profile, high impact paper published back in 2013 in the Journal of Clinical Oncology from Dr. Sungi and his group at Hopkins. And they assessed oncologic outcomes of Black men with very low risk prostate cancer who were candidates for active surveillance but elected to undergo radical prostatectomy. So they studied 1,800 men, 256 of which were African American, and over 1,400 were white. This figure from their study summarizes the major findings, which I'll go through in more detail. But the gist of it is that they found that African American men who met inclusion criteria for their study had significantly higher rates of upgrading, which are shown in this graph, upgrading, as well as adverse pathology when compared to white men who were participating in the study. Kappa scores were also compared. And putting numbers to these findings, they found that adverse pathology was more common in Black patients than in white patients, with 14.1% versus 7.7%. Also, the rate of increased pathologic Kappa scores was also significantly higher in African American men at 14.8% versus 6.9%. In a multivariate analysis here, Black race was an independent predictor of adverse pathology in men with extended biopsy sampling with an odds ratio of 3.23. And they define their adverse pathologic findings here. And they also found that Black men in their study had lower rates of organ-confined cancers. And so there were only 87.9% men of Black men compared to 91%. And then there were also greater rates of Gleason upgrading with 27.3% compared to 14.4%. So kind of pulling it all together, the major assertions from this paper are that African American men that met NCCN criteria for very low risk disease were more likely to sustain adverse oncologic outcomes in Gleason upgrading, adverse pathology. They also mentioned positive surgical margins and biochemical recurrence relative to their white counterparts. They also say toward the end of this article that there's a need to develop prostate cancer risk classifiers that are race-based. So this paper led to a lot of published commentary that highlighted concerns about the methodology and limitations. And one of the limitations being that this is a single institution study. So it's really unable to account for inter-institutional differences in outcomes for Black men that are eligible for active surveillance. It's also important to keep in mind that more than 80% of the Black men in this study lacked pathologic findings at prostatectomy. And that's important because had adjunctive tools been used for these men, they may have remained candidates for active surveillance. Also, upgrading doesn't have to be an endpoint. More and more data is showing that patients with intermediate risk prostate cancer may also benefit from participation in active surveillance protocols. So there were a variety of studies that were in agreement with the Hopkins findings, but there were also several that discovered contradictory evidence. And I wish I could go through many, many more than just this one study. But for the sake of time, I'll discuss this paper. And so this table is from a retrospective study of prospectively collected clinical, pathologic, and oncologic outcomes of men with low-risk prostate cancer from 7 tertiary care institutions. And they looked at men who were eligible for active surveillance but underwent radical prostatectomy with the goal of assessing for racial disparity between African American and white men. And this looked at 2003 to 2014. And they found that there was no racial disparity in the rate of upstaging, upgrading, or positive surgical margins. And they also expressed that since all 7 of these institutions demonstrated no significant racial disparity, that current active surveillance eligibility shouldn't be modified based upon race until we actually have a solid prospective study that's been completed. And so just to throw it out there, the institutions that participated included Rutgers, Temple University, Thomas Jefferson, City of Hope, Northwestern, and University of Chicago, as well as Georgetown. So in tailoring active surveillance to African American men, it's going to be really important to not only establish more concordant literature, but also to continue to develop programs and solutions that actually work collaboratively to alleviate factors that drive race-based disparities in prostate cancer outcomes. And I included a list of them here, but this isn't an exhaustive list. And I highlighted the physician mistrust just out of my own personal interest, because there's a multitude of research that shows that African Americans in general have less trust in their healthcare providers than when compared with Caucasian Americans. And so that may affect physician influence, which has been found to be the greatest contributor of patients' election for active surveillance. Getting back on track, taking a closer look or talking a little bit more about whether or not there's actually a biologic component to this. Some people actually debate the extent to whether or not biology plays a role in driving some of the disparities. And this study from European Urology sought to validate an oncotype test that's predictive of recurrence of prostate cancer after radical prostatectomy and adverse surgical pathology. And it also found no significant differences in tumor aggressiveness by race. And the study from JAMA assessed data on prostate cancer mortality in a SEER cohort, VA cohort, and a cohort of randomized clinical trials. And they found that when you control for non-biological differences, like access to care, socioeconomic status, and standardized treatment, there's no significant difference in prostate cancer mortality. There was, however, a very big difference for other cause mortality when looking at Black race. So in summary, unfortunately, there's no answer, and there are a lot of unresolved questions as it relates to active surveillance, regardless of race. But I really wanted to highlight that there is a substantial discrepancy in the literature which makes excluding Black men from active surveillance protocols or recommending race-based modifiers that dictate eligibility is very premature. And in thinking about how we can begin to tailor surveillance to this population, it'll be important to consider adjunctive strategies like repeating biopsies at 1 year, fusion MRI, and genetic prognostic tools. These things will not only help to improve accuracy in identifying appropriate active surveillance candidates, but it may also help to improve tolerability and adherence to active surveillance in this population. We also should really consider the public health implications of our published work and kind of how that can have adverse effects for populations that really do need protocols like active surveillance. So that kind of wraps up my talk. These are my references. I wanted to, especially thank Dr. Liebman for helping me to find a little bit of order in this talk, and I'll take any questions.